Greetings, everyone, and thank you for joining us in my conversation with my friend, Dr. Pinky Ngaka. Very important topic, early COVID-19 treatment. You know, timing is very important with this contagious virus. My name is Viwe Mchonji, and I'm in Pretoria, in Gauteng, and Pinky is in Gqeberha, formerly known as Port Elizabeth, in the Eastern Cape. Pinky is a specialist physician in private practice. And on my side, I'm a development professional in education and public health and currently working in HIV prevention. So both of us are very passionate about health and the prevention of disease. And as believers, we feel the responsibility to share information. Last year, on the 28th of June, 2020, Pinky and I had a conversation that was seen by close to 5,000 viewers. And it was her last day of isolation. She had contracted COVID and shared her experience to educate, to encourage us, and to give hope. And we received very, very good feedback. I remember people saying that, you know, they dealt with the virus better when it came to them. Now, today is 17 months since the first COVID-19 positive test in South Africa, and many have tested positive, many got sick, and some recovered, and sadly, some lost their lives. As we know, 2.37 million tested positive, 2.15 have recovered, but sadly, 69,488 have lost their lives. Now, to the people watching, this 69,000 is not just a number, it's a person who's a loved one, a family member, a colleague, someone we personally know. So for many, it's not just about the statistics, and for us as well. So I'm going to invite now Pinky to join me as we get more information and empowerment. And please make sure you write your questions. There'll be an opportunity for us to have a discussion. Hello, Pinky.
Hi, Susie, and greetings to our viewers. Thank you for coming and joining us.
Mm-hmm. Thank you so much. And it's so nice this time around. It's much better than last because remember, you were just in isolation on your own. But now you have been back at work and a lot has happened since then. Maybe let's just start. Let's start at the beginning because I think you wanted to share with us why would like us for us to do this.
I think I am moved, especially by the people that I've been treating, meeting them very late in the disease process, and finding that I am losing more patients than I wish I could, and understanding the pathophysiology or the pathogenesis of COVID-19 infection. I felt I needed to raise the alarm and ask our clients to come into hospital or to come in to seek help earlier than later. So really, I am really devoting this presentation or this discussion today to the families who have lost loved ones over the years. And just to give them hope, to say that the experiences that we have learned over the years or months have actually given us a much better hope to heal the land and rid it of the infection that we have in our midst. It's a pity that we have lost their family members, but our sadness and our grief towards their own loss is making us force through and understand the disease better and get solutions even much more aggressively. So this is really a devotion, a sincere devotion to all those families who have lost their loved ones on COVID-19.
Wow. Thank you. We appreciate that. And I do want to start also by saying we share our appreciation to all the health workers, doctors like yourself, nurses, all of the people in the sector who have made it a point to dedicate their lives in ensuring that we get well, we get tested, we are able, to get better. I think because of the nature of what we're talking about, I'd like us to start with a word of prayer so that as we also think about the families who have lost their loved ones, those who are still in hospital. I mean, we know this is much bigger than us. Let's have a short word of prayer. Our kind and loving Father, thank you, Lord, for this opportunity for us to speak to the nation, to our friends, to everyone who has been affected by this pandemic. In a special way, we think of all of our medical professionals and we bring them to you so that you can give them strength to continue with this good work. We bring families who are in mourning. We bring the patients who are fighting for their lives in hospital. We pray that you may cover them with your strength and that your healing hand may be over them so that they may be reunited with their families. Thank you for answering our prayer. Be with Pinky as she shares this with us. In Jesus' name, amen.
Amen.
Right. I think one of the things that I felt was very important that you said when we were preparing for this is just the importance of naming this virus properly. Why don't we start there? Because, you know, naming things is always very critical in whatever the field.
Sure. Yeah, viewer, I like I love words. And for me to just summarily call this virus that is causing this COVID disease, to call it SARS-CoV-2, it's a summary of a very significant phrase that kind of describes to us what we are facing or what we are dealing with. When a person gets COVID, they've got an infection or a disease that arises from a virus called SARS-CoV-2. But I want us to look at SARS-CoV-2 because that is where the meaning and the heaviness or the seriousness of this disease is all entailed. When you're talking about SARS-CoV-2, we're talking about severe acute respiratory syndrome. And then when we're saying severe, immediately that virus that is coming and knocking at the door of your heart or at the door of your lungs, it is coming to cause a severe disease. It's not just coming in to give you a mild flu or a bad day. It's coming in to give you a severe disease. So immediately you understand that you're not playing with a minor entity. And then it's acute. So it means that the speed with which it wants to get you and I to the grave is urgent. Acute means it takes whatever disease entity or whatever progression of the disease, it's going to happen within a short space of time. That is what it means when it says acute. And then it's severe, it's acute, it causes respiratory involvement initially. That is what we call, it can be the upper respiratory tract or the lower respiratory tract, but it's respiratory disease. But then it's a syndrome. A syndrome is a group of many other conditions occurring together. So in that syndrome, you can have a stroke if it affects the brain. You can have the heart involvement if it affects the heart, kidney involvement, liver, or any other disease entity. But it happens together as part of this severely acute respiratory disease. So when we're saying a person has got HIV, we just take it that they've got HIV, but then it's human immunodeficiency. The whole thing about HIV is the immunodeficiency. It wants to render a person immunodeficient. So I want us to really take SARS-CoV-2 for what it means, for what it says, what it claims to come and do when it comes to infect us. So we talk about SARS-CoV is COVID virus. I mean, SARS coronavirus, number 2, because there was number 1, the SARS, the first SARS epidemic. So when we're saying a person has got COVID, it's a matter of time before that disease becomes severe acute respiratory syndrome. When you go to the doctor with that throat irritation, it carries within it the potential to just turn and become severely acute respiratory syndrome. When we feel those chills, they may feel like chills of ordinary flu, but no, that is not a flu. You're carrying something that has come with the intention of being severe and acute. So today you are fine, the next minute you are dead. Today you are walking in the streets, the next minute is your funeral. So I don't want us to be complacent when we catch this infection. Yes, I know that many people can still overcome it. The immune systems are intact enough to overcome it. But now we want to talk about that percentage that we were saying last year is only 2%. That 2% is the reason for the lockdown. It is the reason for us to be still, talking about whatever we're talking about. So it's a very important 2%, and we want to reduce the 2% that dies, and we want to actually bring back normalcy or relative normalcy to our lives. So yeah, I wanted us to start there. I love the fact that we're starting there because we're painting the picture of the aggression and of the virulence of the bug that we are dealing with. We're not dealing with a Mickey Mouse disease.
Mm-hmm. Thank you very much. And I think it's something that you even said last year when we had our discussion. You said, guys, it's not a flu. And I remember you even raised your hand, it's corona, And I like the way you've unpacked it for us. And I think moving then from that proper naming of the disease, and I remember somebody, because I've had 2 tests, because, I had felt that I had some symptoms and I got tested, and I know when the results come back, they actually gives the acronyms that you've just unpacked to us. Now, would you kindly tell us now over time what you've seen in your patients? Because now we are in the 3rd wave. We had started with wave 1 last year around the time you got infected yourself, and then we didn't enjoy our festive season. Remember, we had thought that maybe the summer months were going to come with some relief. It was not the case.
Sure.
And just take us through that.
So when we started off with the original strain that was called the wild virus. So at that time, people were calling it the China virus or the Wuhan virus. That was the original. And then over time, the virus started mutating, which is normal or which is expected of viruses. They change their genetic makeup to overcome or to override the immune system or to escape the immune system. So over time, it started mutating or changing. And every time it changed, instead of it being less virulent or less aggressive, it would become much more, it would have gain of function, if I may put it that way. It would then become a little bit more sinister in terms of how it would maybe infect us. So then we started, the first, one of the earlier mutants was called the Alpha variant.
Okay.
It was found predominantly in the UK.
Mm-hmm.
Then subsequent to that, we got the Beta variant, which was found predominantly in South Africa. But with each and every variant that comes, it tends to replace the one before it. With time, we got the Delta variant, which is the variant that was found predominantly in India, responsible for the pandemic there in February, March this year. There are other variants. I mean, the Brazilians were dealing with the Gamma variant. Then there are variants of special interest. They talk about the Delta Plus variant. And now they're also talking about the Kappa Lambda coming later on to us later on this year. There are many other variants of special interest and so forth. So basically what it means is that each and every time we move over a wave, the virus is also taking over, trying to prepare itself to become more dominant and much more resilient to escape the infection so that it can infect more people. I mean, there's a battle between us and the virus. It's like the battle between humans and the microbiomes. So essentially where we are at right now, we are with the Delta variant. I wish to say that the Delta variant is not as deadly. I wish I can say that. Probably not as deadly as the other. It's not more deadly than the variants that came before it, but the nature of its infectivity, it is highly transmissible, meaning that it infects more people in terms of its infection or in its infectiousness. It infects more people at a time than the ones that came before it. So if there are 100 people in a room, you are more likely to be infected, say 90% or 80% will be infected. In fact, they're talking about it being 4 or 5 times more transmissible than the variants before it. So in terms of its infectiveness or its transmissibility, you get more people infected and the rate or the risk of death, therefore, in numbers is higher. Not necessarily that is much more disease provoking than the others, but it's more infective in the sense that it passes through to the next person much more easily. So the Delta variant also is a little bit different from the other variants that came before it in the sense that the symptoms, whereas before we would get the loss of taste and the loss of smell, this one, that was not as the early phases of the disease. This one, people get an ordinary flu, which is why we get so complacent because we have a flu. It's June, July. We expect to have a flu. So we think it's normal, but it's not normal. The loss of taste and the loss of smell come later on in the disease progression.
Right.
So I want us to now start being alert whenever we feel any change from baseline. We need to listen to our bodies and not be in denial. Because people, when you say to them, you may be starting off with corona, and they're very happy to say, no, I went to my doctor. We did a test, a COVID test, and it's negative. No, false negatives are very present. They're very common. in this disease pathology. I mean, in this disease entity. So even if it's negative, it doesn't mean anything. Your symptoms are positive. They make you positive, not the results of a test.
Okay.
So you're not positive because the result agrees with what you have already. If the result is negative, rather trust your body and not the results. Because that's what is going to die is not the lab result. What is going to die is the human being and with the symptoms. And the symptoms have warned us. They warn us to say something has shifted. Therefore, you can't be waiting for the result to confirm it. Yes, we must go for the test. There's a benefit in doing a test, but if it's negative, it means nothing.
Okay, I think that's a very key takeaway point. The fact that believe your body when your body tells you, and the element of the false negatives, and it's actually quite a high percentage. Why don't you now take us through the progression of from the time people get infected? Because
Sure.
I think, yeah.
Can you get the slide?
All right.
Okay. This slide is a little hectic. It's busy, but it's good because it starts us from the very time that we get exposed to the virus. So when you're talking about the incubation period, we're talking about a time when I get exposed to the virus, get next to a person who is infected already, they pass it on over to me or to you. At this time, you are only getting the virus. It's starting to multiply silently in our bodies. It's starting to divide, to occupy space in our throat and the upper airways. It's there, but we're asymptomatic at this stage. So the incubation period for the Delta infection is usually between 2 to 5 days. It can be longer. They mentioned that it can go up to 14 days. So if you've been exposed to a person, it can go up to 14 days, without the symptoms being there. But typically, it's quite acute. So you get an infection today, you are more likely to show the symptoms on Tuesday or by Wednesday. That is the first phase, the incubation period. After having incubated and multiplied within our bodies, then we start showing symptoms. This is where I want us to jump. When we've been to a super spreader event, or when we've come close to a person who coughs or sneezes, just listen to your body. 3 days later, 2 days later, be aware that stuff may start coming, may start showing that you have been infected. So the minute you become symptomatic, it mustn't surprise us. In fact, you should be waiting, anticipating that we probably are infected. Because like I'm saying, the Delta infection is quite aggressive in terms of its infectivity. So then it replicates, we start developing symptoms. The first common symptom is a headache. Some people get chills. Other people get a sore throat, sneezing, cough, a dry cough. Initially, that is just from the upper airways, from the irritation of the throat. Then you get the myalgia, which is the generalized muscle aches, severe fatigue as the disease progresses. This is where you get the nausea, the vomiting. Some people, if they've got gastric COVID, and so forth. This is the stage, the symptomatic phase, which I want us to really jump. I want us to start being active whenever we begin to have symptoms. Whenever you have a flu, please know it is not likely to be a flu. It is unlikely to be a flu. It is more likely to be COVID. Why? Because we're in a pandemic. And when we're in a pandemic, common things occur commonly. And the commoner thing between the two is COVID than a flu. Then the third phase of the disease, we call it the early pulmonary phase. After having been exposed to our bodies, then the antibodies the cells of our bodies, the white cells, start recognizing that there's an invasion. So those are the soldiers in our bodies. They notice that there's an invasion, and then they start acting according to the best way they know how. The first thing that they do, the macrophages or the white cells start gobbling up the viruses. In gobbling them up, they found that the higher the viral load, the more the disease process or the disease expression becomes, because there's much more cells now that are gobbling up all these viruses that are in the airways. When they gobble them up, they also send signals, chemicals, or cytokines to the other cells that say you must differentiate now and become plasma cells. You must differentiate now and become cytotoxic cells. Please come on board and give us antibodies. Make antibodies. We've got an invasion. We need to destroy and dissolve these viruses. Cytotoxic cells come now and aggressively attack these cells because we can see there's danger that has come on board. If your immune system and mine is good. By day 10, 7, 8-ish, actually by about day 7 of having the first symptom, we should have managed to clear the infection, because the processes in our bodies are going to be so jacked up and they're going to be accurate. They're going to send the right antibodies at the level that they needed. The cytotoxic cells are not going to start working against us. Everything is going to go smoothly. Sure, you are sick because you get all this inflammation going on in your body, but it's going to be harnessed properly, and you and I, we heal. That is by day 7. The problem is, if by day 7 we have not cleared, the immune system has not managed to clearly clear the infection off of our systems, we enter into a stage called the immune phase. In the immune phase, this is when we start having immune dysregulation. The virus is starting to dwindle down, but the immune system is becoming dysregulated. It is producing cells and cytokines or chemokines that are working against us instead of helping us. And when they do this, they produce a severe inflammation, which changes that viral infection, that upper respiratory tract infection, into a lower respiratory tract disease. We call it a pneumonia. It's the early pulmonary phase. We call it a pneumonia at that time, which is still very early, because the body is still battling to rid the infection. Even though it may rid the infection, but there's still a lot of disharmony of the immune system, sometimes overly expressing the chemicals that they're supposed to help us, and they start working against us. This is when we start getting shortness of breath. This is when we start feeling sick and getting despondent, a hunger, and so forth. But later on, if we don't manage to break this cycle, we get into a stage now called the cytokine storm. And the cytokine storm is that which kills us. It's no longer the sore throat at this point. It is now ICU. We're no longer talking about taking aspirin and taking whatever. We're talking severe medications. At this point, we are talking. So now, before I get carried away, whenever you're looking at these different stages, the viral phase, that is where we apply the early treatment. That is where we want to apply the early medication. At the early pulmonary phase, this is when people start taking they start taking steroids, corticosteroids, and they need to take anticoagulants. They also may need to take antibodies, but at this stage, this is where we need to start being very aggressive. And then the third and final stage, that is where people get admitted to hospital, especially, and they need to be ventilated if ordinary supplements of oxygen do not give us the right amount of oxygen levels that we need. So for me, I want us to focus on the very early symptomatic phase. That is where I feel we can overcome the disease. Yes.
All right. So then what it means, Pinky, is that as I'm looking at this graphic, it's critical that at the incubation and symptomatic stage that we really address the virus, right? So because I think what tends to happen, well, for what tends to happen with many of us, we tend to think, man, I'm so used to the symptoms, and so
yes,
I always have a flu in June or July. You know, it's the time, the time of the year, and we are thinking, no, I don't. And I think another issue is that people always say that if I go to a doctor, maybe I'll have to go to hospital. That fear. How do we deal with that?
The reason why we want to have these meetings, Viwe, and these teachings is so that people can understand that all these funerals that have taken place, they started off as a flu.
Okay.
By the time we start lamenting that so-and-so has died, by the time we talk about the numbers of death rising in the Eastern Cape and in Gauteng, it started off as a flu. Nobody comes and gets to the stage of the cytokine storm without having been through the flu phase. So I really beseech you, brethren, of my nation, fellow South Africans, I really beseech you, do not assume it is a flu. Rather, overly treat a flu than undertreat COVID.
Okay.
Because the only time you can change the course of the disease, if you take antivirals very early in the disease process, and if you can nip that COVID in the bud, at the bud phase, don't wait for it to become a giant, a dragon, before you then become desperate. It's too late. Let's be desperate at a time where we can do something about it. And that is the symptomatic phase.
Oh, thank you so much. Would you kindly share with us as to what are some of the successes that you've had, be it some kind of treatment or, let's spend some time on that. Mhm.
Mm. So the last two waves were a bit difficult because we really didn't have any word of hope to offer to our patients. It was like you diagnosed with COVID today, you have the symptoms, you diagnosed with COVID today. We can only give you treatment that is for the symptoms. If you have a sore throat, I'm going to give you lozenges. If you've got backache, I'm going to give you something for pain. And we say go and sit it out at home. If you're sick, then you come to the hospital. But that is practically asking a person who comes and tells you as a doctor that they have COVID. And you're telling them, okay, fine, you may be lucky, your immune system may help you. So the best immune system will win. Or if it's not, if you're not lucky, then when you are very sick, come to me and then I'll try and see if I can get you out of the hole. That is not a very promising, you know, discussion with the patient, between the patient and the doctor. It's like saying, okay, fine, I know this disease can kill you, but I don't have anything to offer you because really we didn't have anything to offer at the time. So over the months, there's been desperation. I mean, scientists naturally, that's what they do. They go and find solutions. That is what medicine is about. It is to alleviate suffering. And we
Yeah.
did not have much to alleviate suffering at the time. So really we lost a lot of people in the first and second waves. But the difference between me
Mhm.
and a doctor who works, say, with, let me just say, another specialist in another, entity, in another field.
Mhm.
Say, I'm not trying to pick up on anyone. Let's say a psychiatrist. They don't see medical patients the way I do. I am by the bedside of that patient. I go to them, I see them hungering for air. I can give them water, I can give them oxygen, but I can't force that oxygen through their lungs because by the time we get to the cytokine storms, the arteries, the smallest arteries of the lungs are clotted.
Okay.
And whatever oxygen that you try and push, you have to deal with the red cells which are clamped together, and they can't even receive the oxygen all too well. And if they
Mhm.
do, there's just so much that's going on in the lungs that it becomes futile. The question is, why must I wait if I can do anything about it? Why can't I abort this stage so that we don't come to this stage? So this phase now, there's been a lot of literature. We've tried antivirals before. There is an antiviral that we tried that we have been using, faithfully in the first and second waves. It didn't give us much in terms of clinical outcomes. It didn't really improve the course of the disease. It didn't really improve or stop the deaths that we're seeing. But we're using it because that was the only hope that we had. Then
Okay.
came the breakthrough with corticosteroids, intravenous corticosteroids. They reduced the rate of deaths by 30%, 32%, which is something commendable because we wanted to have anything that we can lay our hands on. Then we had drugs called interleukin-6 inhibitors, which are critically important in the inflammatory phase of the disease because they break the cytokine storm. They're supposed to break the cytokine storm because interleukin-6 is a cytokine. So these are inhibitors of the cytokines, which drive the cytokine storm. We tried those, they would work sometimes, they wouldn't work in other times. But with the one thing that we were crying and lamenting is there anything we can do? First of
Okay.
all, to say to a person who's going to a funeral, here is a medication that you can take if you know you're going to be exposed to a high viral load or high viral burden. Take this and protect yourself. Is there anything we can say to a person who has been exposed without knowing them? Okay, so this is pre-exposure. Post-exposure,
Okay.
if I come in contact with a person who's tested positive, then is there anything I can do to make sure that the incubation period doesn't last that long? Or is there anything I can do, I can take now that the virus has multiplied to reduce the viral burden and give me hope at that time so that we don't go to the stage of the cytokine storm and in the pulmonary phase? And we studied. I mean, we're looking at our colleagues overseas, what they've been doing, because they've got the infection much earlier than us, so they've done much more greater strides than we have. And we found that there is a molecule called ivermectin. It was there, it has always been there, but it has been repurposed to try
Okay.
and reduce the pain that we see daily in our wards, to alleviate the suffering not only of the patients but also of the treating doctors, because we're also as exposed. We
Yes.
are, we
Yes.
are as exposed to the pandemic as everyone else. When you go to the ward, what protects me other than the PPE? Because I've tried the PPE, it failed me the last time. And what do I know about PPE now? Is it going to fail me again? So what I'm saying is, we're not just fighting for the patients to get well when we're giving them
Yes.
these medications. We're fighting for our own lives at the
Yeah,
same
you're
time.
fighting for yourselves as well.
We're fighting for
Yeah.
ourselves. Yes, so whatever breakthrough medication there is, it's a breakthrough for me. I'm excited for me, as well as I'm excited for my patients. It's not nice to see a colleague, a nurse that works with these patients, nursing the same patients that may kill them. It's not nice to see this. It's just not nice. When a person dies, viewer, we admit them in wards, for an example. They may be in a 4-bedded ward. This is Mr. So and so, according to us. But Mr. So and so is used to sleeping in his bedroom with his wife and in his household with his children. We see Mr. So and so, we call them bed number 11.
Yeah.
They're bed 11. No, they're not bed 11. They are husbands and wives. They are mothers and fathers, daughters and sons. So when you go to bed 11, there's a phone call waiting for you to try and explain the condition of bed 11. And that person on the other side is not wanting to hear about bed 11. They want to see the condition of their father or their mother or their daughter or son. So when there is something that is promising, even if it can just give us some degree of hope, and if you combine that with corticosteroids, we are winning the battle somewhat, because we're dealing with a virus that is called war. It has declared war with mankind. It has imprisoned us and put us in jails, in our houses. We cannot do as much life as we would ordinarily do, and we are looking for a way out. And for me, ivermectin has been that great molecule. So to say, do I have a testimony? I have testimonials. Maybe when we come back again to the quiet place, we'll make noise with the people that have been saved, whose lives have been saved, families who are thanking the day that they met ivermectin. And it's really a wonderful molecule. I've got so many of those stories.
Wow! This is amazing. Maybe tell us a little bit about that, because I've had some people saying that ivermectin is for animals, but at the same time I've had some said no, this is something that has been just give us, because the background is going to help us. What has been? Would you give us the history of
ivermectin?
Yeah.
So this is now Professor Omura. This is Santori Omura from Japan.
Yeah.
Trying to discover new antibiotics or new treatments. Take soil or ground from some golf club or some golf course in Japan somewhere. He takes this piece of ground. I think he must have sensed that there's something there that was different or whatever. He does something, he ships it over to America, works with Campbell, and they discover that there is actually a microbe called Streptomyces ivermectilis. And this microbe is producing anti-parasitic agents.
Okay.
Or it has got some anti-parasitic properties within it.
Oh, wow.
Then they multiply.
It's from the ground. It's from the soil. It's from
Mother Earth.
Okay.
It's not an invention of anyone. It's a discovery. It's been there, but it's found solely in Japan. It's not found anywhere else. So they discovered this Streptomyces ivermectilis, and then they discovered that it has got these properties. This drug or whatever, these molecules have got these properties, that they're anti-inflammatory, they're anti-parasitic, they're also antiviral. Even then, as early as then, they were aware that it's antiviral. But then because of the burden of the infection of the parasites at the time, then it was purposed, or it was indicated for parasitic infections. Among the parasites that it was used for, or that it was discovered for, it is useful for both skin parasites and endoparasites. That is exoparasites and both endoparasites. That is, it's used for worms, it's used for scabies, it is useful for even resistant scabies. And dermatologists in South Africa have been using it. It was used before, and it was developed by Merck, big company, like one of the companies of the pharmaceutical companies. They produced it, and it was discovered, it was tested, at leisure. The safety properties of the drug is unknown. The nature of the way that it works is well known. In fact, so amazing is the molecule that it received a place in the WHO's essential drug list, and the discoverers of the molecule were given Nobel Prizes because of the amazing drug that they discovered. Fast forward, this is now 1975, 81, 1986. Africa was given like bucket loads, and like billions and billions of doses have been dispensed to the Africans for free for the treatment of onchocerciasis, which causes river blindness, and for the other treatments of filariasis, which causes lymphedema, worms that are difficult to eradicate otherwise. And ivermectin was very useful and came in very handy. To this day, Africa is still using ivermectin for the treatment of these parasites.
Oh, wow.
Then,
This is
yes,
just sorry to interrupt.
humans, this is humans.
Just sorry to interrupt, because when I was listening to you talk about worms, talk about scabies and all of those things, these are mostly issues that would affect us in the developing country, right? So,
Yes.
oh, wow. Now, as you say this,
Yes.
I'm thinking, could there be a link? You remember when COVID first came, they had said to us, "Oh, it's going to wipe out this continent from the face of the earth." Anyway, sorry, I interrupted you. Just that I got excited. Yeah.
Sure.
Yeah.
It's very interesting. I do not want to associate the presence of ivermectin with the low numbers that Africa has really had, because when you're looking at Africa, the only countries that have been hardest hit are really Egypt and South Africa. I'm not aware of the use of ivermectin in Egypt, but I know that throughout Africa, ivermectin is one of the drugs that are used a lot, as well as chloroquine. So those two drugs have been used for, one is for malaria, the other one is for these parasites. I don't know if there's any association, but Africa has been really relatively mildly hit with COVID compared to South Africa specifically, because we don't have much malaria here, so we don't use much chloroquine, and we don't have much ivermectin, because ivermectin in South Africa really became redundant because we don't have this kind of parasites in the rate that the other African countries have. So over time, because there is this molecule and it has got this good and efficacious indications, then in South Africa, we had to apply over time. They took it away because there was no one who was interested in using ivermectin. So it was taken away. Otherwise, it was a Schedule 3 drug here in South Africa. So it was taken away over time, after some time. And then because there was the molecule and there was an indication for the veterinary use of ivermectin, and then it was used for worms and parasites in animals. But it was developed as a human drug for humans. So when we come and speak about the toxicity, we're using a molecule that has been used over and over by so many people, many years over. So we are not scared of the molecule. It is a safe molecule. In fact, it is a brilliant molecule. We cannot overemphasize that.
Thank you. I think it clears a lot of things for us. The fact that it comes from Mac, for example, and it has been used over time, over the years, and for something that has helped. And so I think then perhaps it would be critical for us to invite some of the people, because I think what spoke to me as someone who works in HIV prevention, the issue of a pre-exposure prophylaxis and then the post-exposure. So what are some of the results that you've come to see in your patients? For example, perhaps if you can give examples for people at different stages.
Sure. So what I say, viewer, is it's used for pre-exposure prophylaxis, ivermectin. It is used to make sure that you don't contract the virus, together with all the other safety measures, hand washing, social distancing, using your mask, and so forth. We use it. So for high-risk individuals, people who work with patients or people who have COVID, then it's safe to use ivermectin. It is indicated there. Then we also I've been taking ivermectin for pre-exposure prophylaxis. I've not had, I had the beta, was it the beta strain that I had? I had the beta strain.
Yeah.
The
first one was beta.
No, actually, I had the first one. I had the original, the wild type that was in June, because the beta strain came around in the second wave. I had the original.
Yes,
so my antibodies were formed against the original.
Yes.
I don't know. I haven't tested to see if I've got antibodies. And even if I were to have antibodies, I don't know how efficacious they would be against the Delta strain. But even if they're efficacious, it would be lovely. But I'm taking ivermectin to protect myself from getting infected to begin with. So it is used for pre-exposure prophylaxis. It's also used for post-exposure prophylaxis. If you are in contact with a person, if say I'm at home and somebody comes and visits, maybe, or my husband comes with COVID. Unlikely it should be the other way around, but He could be taking ivermectin to protect himself from getting it. If I were to get infected now, he would be taking ivermectin to make sure that he doesn't get infected himself. If I were to be, to be positive, so I would use it for post-exposure prophylaxis in his case. And then if I were to get infected, then I take it for treatment purposes. So there's 3 types of people in a household. For an example, if I were to come back home now with the infection, some of us in the household will be taking it for treatment. That would be myself, my husband, and my children, and the other people that stay with us would take it for post-exposure prophylaxis because they've been exposed to a person who's infected.
Oh.
It works brilliantly. There are many studies over and over again. Now, you must remember there is now a huge misunderstanding. I'm going to call it a misunderstanding of how ivermectin is supposed to do what it does. People have done trials over, and there are myriads of trials that have been done on ivermectin, and none of them have shown uselessness of ivermectin. There's a study now that has been published from Argentina that says that ivermectin is useless. But what I like about that study, it came back and said it is safe. For me, because I'm a firm, ivermectin user, and I've seen it being useful. I take from that article the fact that it is safe. That for me is the saving victory, that at least it is safe. And that's what we've been saying. It is a safe molecule. So if I'm giving you something that is safe and useless, what can I be causing harm? What if it's safe and useful? If I give it to you and it's safe and useful, what would then be the gains and the losses if I were not to use it? I've been giving patients safe and useless treatment all throughout the time anyway. I've been giving them colchicine. Even before colchicine went into clinical trials, it is safe, but it turns out that it's useless. But I've been giving it because it has got properties that are supposed to deal with the infection according to the nature of the viral infection. I've been giving patients vitamin C because it is supposed to be an antiviral. Is it useful? I don't know, but I've been using it. Because why? It is safe. Why can't we use a molecule that is safe and possibly useful? Because all the clinical trials, the bulk majority of the trials are singing one song, that it is highly efficacious and it can turn the tide of this whole thing. I'm really praying. I really don't know what else to say.
Just sorry to interrupt. I know. I think when you do this, is it randomized controlled clinical trials, and then perhaps for some you don't do anything. In some cases, you give a placebo. There's no harm in a placebo. Like if people are calling it a placebo, then it's not a problem.
A safe placebo. I'm happy to give, but then lo and behold, this placebo does wonders. It works better than some of the so-called treatments. And I don't mind. I will take any treatment viewer, because all I want is for that father to go back home, that mother to go back home. I want that daughter, that son to not die before his or her mother or father. I really want people to live.
Now, like perhaps 1 or 2 examples now in terms of time. How long does it take for you to see the results that it has been effective?
In early infection, most people come back within 48 hours and they report feeling better. 48 hours in early infection. So when you say people must present ideally within the first 3 days, I don't know why they don't present the following day. But the thing is now, because there's a big war against ivermectin, there is a big debate. There are doctors who are for ivermectin and doctors who are against ivermectin. It has divided. This whole COVID thing has divided the world of medicine into 2. In every aspect of the world, divide. It has divided us into pro this, anti this. Pro this and anti this. If you are pro this, you are supposed to be anti that, and it's not supposed to be the case. I don't understand why we can't be pro treatment and pro patient. In our quest to dealing with this virus, can't we just be pro treatment and pro patient and antiviral in our approach? That's all I'm pleading for. Can we stop fighting against each other? Because now what happens is that we're going to have a talk like this. People are going to want to try this ivermectin molecule out, but then they're going to go to their doctors who are going to refuse to script it. Because now all of a sudden, no, they don't believe that ivermectin works. Yet the patient is requesting to have this, to try it out. So what do you believe works, doctor? No, I believe that flu treatment works, but this is not a flu. What are you giving me? When you're signing that prescription, you're giving me prescription for something that I don't have. I have a COVID. I've got SARS-CoV-2. You're writing for me a script for flu. That can't be normal. That can't be right.
Mm-hmm.
And doctor, I just want to try it out. I want to try it out. And I need your signature because you are the one who's qualified to have this engagement with me, to allow me to try whatever I need out. Is it really such a bad thing to ask?
I think for me, what gives me comfort is the fact that this has been used by humans since the 70s, as it was used
Yes.
for all of this. So, which means it has proven to be useful and to be effective. But I
No,
want
it's a
us to.
human drug.
It's a human drug. Yes,
It's a human
yes,
drug.
exactly.
Animals are getting it by the way, but it's
Uh-huh.
our drug.
Okay. All right. Thank you so much for that, Pinky. I would like us to just talk about just a few myths because when you've got a pandemic or a disease, there are some myths as well. I think one of the big ones is this issue of people being afraid because they hospital. Can you tell us, because as someone who does see patients in hospital, just reassure us again that people do come back. Kuyabuywa esibhedlela. Umuntu agoduke abuyele kokwabo. Can you just assure us on that one?
People come back from hospital, come back live and kicking and everything. When a person comes to hospital, okay, so there's early treatment, but there's also early hospitalization. If you want to win this battle against COVID, please remember this thing. You are exposed. If you have been attending, if you've been exposed, you've been around a lot of people in the same confined space, know that you are likely to be infected. So you must preempt it. If you don't have ivermectin to take for pre-exposure, maybe take it as post-exposure for post-exposure prophylaxis, because chances are you have been exposed. But count now from the first day of your symptom. Count that as day 0 or day 1. Let's just count it for day 1. From day 1, take your treatment, ivermectin, with everything else that it goes with, because don't take it alone. Take it from day 1. But please, not day 8. Day 8 must be your day when you note what's going to happen, because that is when this thing changes from becoming a mild throat inflammation, or it becomes severe. Note for me day 8, because there's treatment that you must take at day 8 if you don't get better. So if you don't break this disease by day 7, day 8, get up and go to your doctor. You have to have a certain number of blood tests that must be taken from you. You're going to have to do a couple of other tests that must be done so that we can now start predicting the nature of your outcome. Are you likely to have severe respiratory failure? There's a blood test that we do at day 8. Are you likely to progress and need ventilation? There's a blood test that we do at day 8 of the infection. So don't come at day 9, because day 9 it may be too late. Don't come at day 10, and a lot of admissions come at day 12, day 14, and it becomes difficult to fetch people from that hole, because I work in hospital. Yes, we've got success stories. We've got a lot of those, especially for this wave. I've discharged a lot more patients than ever before, before in the first and second waves. We've discharged a lot more patients here. We've got less deaths now occurring because we are much more aggressive. For an example, in the first wave, second wave especially, we'd sign not less than 4 death certificates a day. That means you come into the hospital, you left 20 patients in the wards. When you come back, 4 of those are gone. And what do you think? 4 patients are already on those beds. 4 other new patients are on those beds, also looking like they're about to die. So the following day, you have another 4 sets of death certificates that you're signing, and those beds become occupied within no time at all. So we're working, it's like we're just accepting patients only to watch them suffer and die. But this time around, we've seen so many people walking out. Yes, some people take longer to walk out of hospital than others, but people are coming out of hospital because they are coming in much earlier, and we can do something about people who come in earlier.
Okay.
So ivermectin needs to be taken early.
Sorry for this off ramp I'm taking, but I'm the queen of off ramps. You actually sign death certificates as doctors?
We sign them, and this is what I say. I would rather be signing a script for ivermectin than to be signing a death certificate. You sign them because you are the one who certifies the patient dead.
Oh my goodness.
So you have to put the cause of death there yourself.
So anyway,
it's not the most pleasant experience, Shane. It's just not an experience that one wants to be doing.
All right. Sorry, Sissy, I interrupted your train of thought, but you were just talking about.
No, we need to early treatment, early hospitalization, early treatment, early hospitalization, day 8. If you don't feel well at day 8, don't think that you can take it. If you start having shortness, that's when we start developing shortness of breath, because that's the early pulmonary phase. So don't think it's just a starting, then this shortness of breath is starting to break. No, you didn't break it as a flu. What's going to make you break it as early shortness of breath? You see what I'm saying? The logic that I can handle, you can't handle it. Go to hospital, see a doctor who is willing to treat you. The beauty about 2021 now, there's telemedicine. Phone a doctor who is willing to treat patients with ivermectin, because some doctors are not willing, and I understand them. I was like that doctor as well. I was a person who was waiting for evidence-based medicine. I've got my evidence. We've seen the clinical trials. I believe in the evidence because I've also treated my own patients. I've got evidence. But now the thing is, we are used to getting evidence from specific entities and specific people. It's like if the WHO doesn't give us the evidence, then I'm scared of the evidence. It's evidence. Because it's not all scientists that are working for the WHO. There are scientists outside. I mean, even if everyone of who's a scientist would work, that they wouldn't have space to accommodate everyone. So there are definitely scientists outside of the WHO and all these big bodies. We respect that what they are doing for us, and we really acknowledge what they are doing for us. But if they cannot answer some of the questions that we need, we thank God for having other scientists that are willing to search out the matter and give us the solutions.
Okay, Sissy, we have some questions, because we do not want to. We had promised our viewers that we will answer. We'll get to some of the questions, and we have them on the screen and also on our devices. I need to. Sorry to do this. I forgot I'm over 50. I need to get my glasses so that I can see. Okay, I think one of the questions that is asked is, can pregnant women take ivermectin? That's one of the questions.
Say that again, viewer.
Pregnant women,
No.
safe.
No. The safety in pregnancy has not been established. I don't want us, the thing that we are doing, viewer, as we are busy lobbying for the use of ivermectin, we want to have responsible use of ivermectin. We want to use it to the right person at the right dosages and with the right formulation, by the way. There is a lot of, in pregnancy, let me finish answering that question because I get carried away. Pregnancy, the use of ivermectin is not indicated because we want to protect the unborn child. A pregnant woman, the ivermectin levels in the child will be high, for starters. And we don't know how safe ivermectin is in people under the weight of 15 kilograms. That is the first thing. Also, the blood-brain barrier of a child is still underdeveloped, and it may cause neurological side effects in the unborn fetus. I'm not sure of what it can cause in terms of teratogenicity, that is affecting the unborn baby formation. So we rather not use it for the pregnancy. So no, the short answer is no.
Here's another question. I'm just taking them from the top so that the people had asked first. Please advise Dr. Pinky. On my 17th day, I still have loss of smell, taste, backache, cough, and painful imbambo ribs. Also, I feel some heaviness on the left side as fubeni.
Okay, we have now you can get healed from COVID. That is, you don't die, you get discharged from hospital, and then some people get what is called the long COVID syndrome, or they're called long haulers, or they get chronic COVID. So we said it's severe acute. So many people recover within 2 weeks. Usually, some people can have a more protracted course. They recover, they take longer to recover. And some people can recover and get better, get back to normal life, but then they come out with some stigmas that are left behind in their bodies. So these are the symptoms that we've just put out beautifully. It's like you have COVID all over again, or the COVID has not really left you. Ivermectin is also effective, even in the long haul. This is one treatment that can address the acute phase, the middle phase, some even the inflammatory phases, as well as the long haul. So it would be lovely to just see a practicing physician or a doctor who's going to give you treatment at the right dose for the right duration.
I think that one leads us to the next question, because it says, actually, I think this is another doctor as well. Please, doctor, speak to doses, treatment doses against prophylaxis doses. Ivermectin works. I've used it with amazing response. Yeah, so the issue of doses as a, yeah.
The doses. Okay. We are guided by the FLCCC guidelines. That is the frontline COVID care doctors. Those are that is they're based in America. And also we have information from the BED, the British guidelines. So what happens is when we started off in the previous two waves, the doses that were given, they were much less than the doses that we have currently, because the learning about COVID and ivermectin is evolving. So we get new results and therefore we change accordingly. I want us to be up to speed with the latest doses because people are still stuck in the old dosages. Even pharmacists are still stuck in the old dosages. And I want us to really keep up to speed and be updated to the current, doses that we are now using. So for pre-exposure prophylaxis, this is for a doctor or for a nurse or for a worker in the hospital environment who wants to take ivermectin for prophylaxis. There you take 0.2 milligrams per kilogram body weight. You take it at day 1, you take it at day 3, and you take it weekly thereafter. That's pre-exposure. So you take it on Sunday, you take it on Tuesday, and every Tuesday thereafter. That is for pre-exposure prophylaxis. For post-exposure prophylaxis, you take 0.3 milligrams per kilogram body weight. So if you're weighing 100, you're going to take 30 milligrams at day 1, at day 3, and at day 5. If at any given time you get the symptoms of the virus and you test positive, then you upscale to the max to the doses that are used for treatment. The doses that are used for treatment is 0.4 to 0.6 milligram per kilogram body weight. So 0.2 for pre-exposure, 0.3 for post-exposure, and 0.4 to 0.6 milligram per kilogram body weight for treatment.
Okay.
The duration for treatment, minimum 5 days. We said before 3 days, but now it has gone up to 5 days. We are dealing with a changing variant, with changing variants. So we also need to change our game.
Okay. Thanks for that, Pinzu. There's a greeting from a friend in Canada. But now the next question is, where do we get this doctor? Because most doctors just tell you that even stimming is not necessary and they are just against ivermectin. I guess we will talk to this stimming and stuff like that. I know, just to tell you, this friend, we've been friends since we were 10 and 11. And once
This is the older.
Yes, I'm the older one. So
Yes.
once I had a situation, so I was telling her what I was taking. And then she said to me, Viwa, we didn't get to that chapter in medical school. Can you tell us the chapter on stimming?
You know what? We did not get to that chapter in medical school. And that I really understand my colleagues when they don't want to condone these practices because we really didn't get to the chapter of COVID in medical school. Because COVID wasn't in the syllabus at that time. We're learning as we go now, and we have to be really flexible because ultimately medicine is an art. And this art is evolving. So we have to evolve we can't be stuck when we're dealing with an evolving. It's like we're catching a moving target. We have to move with a moving target and we need to really fix our eyes on what works and what doesn't. So we are using steaming as an antiseptic. It's like if you're using hand washing for, some hand sanitization, we're using steaming for the same reasons.
Yeah.
So a lot of people are using steaming with peroxide. I've got people coming in and out of my bedroom. I've tried to hide, but then they seem to like my space. Steaming with peroxide. Peroxide is harmless, but you need to dilute it to the right amounts. Then we use steaming. And also we use, some people use eucalyptus, betadine for steaming. You just use whatever you think will work for you. But steaming is ideal because it helps clear the airways. I laughed at it when I first heard about it because I was thinking steaming, how scientific is that? But it looks like if you steam faithfully with betadine, with peroxide, those are antiseptics. Then they can also heal and rid the viral load that is sitting in the throat before it gets down into the lungs. So yeah, steaming is adequate. I recommend steaming with peroxide. I I recommend steaming with betadine because those have been found to be antiseptics.
Wow. And I guess maybe doctors can learn from some of the indigenous ways of dealing with, with disease, because I think steaming was there when people have a cold. I remember the first time I experienced this was last year, because I think we were exposed with my mother. Hey, it was an experience. But now I actually like it when I feel like I have been exposed. All right. Now, Bongani has a question here. What are the common after effects for those who had contracted COVID? Bongani is getting a good treatment because he's actually even is my colleague.
The after effects, I think you basically get COVID all over again. It's like you have COVID all over again. But then if neurologically, especially for us people who had the neurological involvement of COVID, neuro-COVID, with the loss of taste, loss of smell, that is a neurological involvement. So some people can get mental fogging. You get forgetful. You have to really write things down if you know you're going to forget them. I make it a point that when I don't assume that my mind is as sharp as I was before, but I make it a point that I write things down so that I don't rely on my mind because people get mental fogging. There are treatments for all of those, but you need to discuss them with your doctor, especially a doctor who's interested in treating COVID. Yeah. Back in the day, the doctors were not willing to touch HIV patients. And I think now COVID has become the new HIV. Some doctors are just not interested because the treatments that they give is like they don't care or they're not interested. So find a doctor who's willing. If you don't find them, telephone, the teleconsults. Maybe I should put a list of doctors who are interested and I'll ask for their permission because now, the POPI Act and whatever, we cannot just share information publicly. But I know that they wouldn't mind. So I'm going to just contact a couple of doctors I know are interested and then I'm going to flight them on the comments section below. But yeah, the symptoms are mental fogging, like forgetful, become irritable. Some people get depressed, they become anxious. That is all part of COVID because COVID is part of its disease expressions. It depletes serotonin and it causes people to feel like they have anxiety. COVID, it can actually people can be diagnosed to have generalized anxiety disorder, not because they have generalized anxiety disorder, but because of COVID specifically. And I think that's what a lot of people die from. They die from this fear that drives the COVID, spectrum even further. So some people get severe muscle aches, especially backache. That's actually one of the symptoms with which COVID can present. Backache, especially here and at the lower back. So that backache is not just because we're exercising more than you normally do, it's because you have COVID sometimes. And then, it's the myalgia, the fatigue. People get tired, shortness of breath. It's like you have a clot in your lungs or something. That's all because of long COVID. You are a long hauler.
Okay, so and then how long does it last? Is it something that you are burdened with for life, or will it come to an end? I'm also conscious of time because I'm aware that we had said we're going to give this an hour. Yeah.
Yes. Long haulers, it can take, you say from 2 weeks after when you expect to have cleared, if it starts developing, you say you have ongoing symptoms 2 weeks after the infection. Some people can last for 6 months untreated, but then it can be very disabling. So you need to get medication as soon as you notice that you're not getting back to your normal self, even though you are now back, you're supposed to be out of isolation and back to what you're supposed to be. Anything that you feel is still resisting to go, present to a doctor. Ivermectin is still useful in those stages, and it really breaks that long haul within 5 days of treatment.
All right. Okay. Thank you so much. I don't know if there's a question that I've missed. Tembi, would you kindly help me with that? For the ones, some are just thank you for some beautiful words of affirmation. Okay, there's one from Klapsi. If I have a script for ivermectin, are all pharmacies able to issue it? Dr. Pinky?
Not all pharmacists are stocking it. Not all pharmacists are stocking it. So we need to have a list of pharmacists that are stocking it in your area. But then there are other pharmacists that are willing to send couriers to their patients or to their clients if you were to communicate with them in time. The most important thing is time is of essence. So if you feel the symptoms today, you go to a doctor and they don't agree to give you ivermectin. Find a tele-doctor who's going to try and sort you out and connect you to a pharmacy that can give you the medication or deliver it to you. The sooner you start the medication, the better. I want to say, please, people, do not self-prescribe. Don't treat yourselves, because honestly speaking, there are many other conditions. I mean, many other treatments that come along with ivermectin. You cannot use ivermectin all by itself. And I don't want to overly give information here, because I know people start becoming junior doctors and they start treating themselves. There are many considerations that need to be taken. That's why you can't phone me and say, doctor, I need a script of ivermectin. Can we do it? We can't do it like that. Medicine is a science. So there's many questions that we need to, answer before we come to a conclusion of what is the best script for you. Because your script is tailor-made to you. You're not supposed to share it with the next person, because there's many indications for other drugs that you need that may not be needed for the next person. We're going to talk together, doctor-patient privacy, confidentiality. You can't transfer that confidentiality to somebody else, even if you love them. We need to sit and discuss separately. So I know that people are going to think that this is a money-making ploy. We are not about to make money this way. We want to help you. I don't even want people to necessarily come to my offices. I need people to come and see their doctors, get a prescription, but just get yourself ivermectin, use it properly in the proper dose at the right time, and get healed so that you don't die.
All right, Bingzo, I think we have dealt with, unless there's some, our tech team, Tembi and Tuka, do you see any other questions? Because I want you now to give us closing remarks. And I think we can promise that we are committed to communicating, and people perhaps can share with us, those who know us. We both have Facebook pages. You can write to us and say, perhaps this is what you would like us to address the next time. But we thank you very much. And again, I would like to thank you, Pinky, for all of this very useful information. I think for me, my key takeaways, the first one is act soon. Let's listen to our bodies and let's believe them and make sure, because the sooner I can get to my doctor and the doctor can address the situation, the chances of me beating this thing are very at that incubation and symptomatic phase, rather than wait until stage 3 and stage 4. I'm giving over to you, Gemam Gcina, to give us any closing remarks, what you'd like to say to the patients you love. I know for you, you're not just a doctor, it's a calling. And I was excited when I also saw my sister looking back at those days, even when you were younger, and very committed to your profession. Over to you, Gesisi, for your closing remarks.
Okay, my closing remarks, viewer. I want us to approach this with boldness and not to be intimidated by the number of people that we see that are succumbing to the infection. I want us to approach it with the boldness that it takes to believe that there's something that God has given us that works. Ivermectin works. It really works. We cannot lie about it. In fact, it works even for people who develop symptoms after vaccination. It works. We cannot say that it doesn't. It really works. So try and empower yourself. Put your hands on as much literature as you can so that we can be comfortable and share this information with other people so that they too can get saved at the right time. Having said that, I want us to be conscientious of the time frames. Do not assume that because you are young. I had a conversation yesterday with a young gentleman, about 35, 36, somewhere there, who contracted COVID, and he almost died because he became hypoxic. That is, his lungs were running out of oxygen, to a point that he became delirious. He was so disorientated for his name, place, and time. And he really took ivermectin, even though he started it quite late in the process. I think he started it about day 9, day 10, and he made a dramatic turn and he improved. This thing works. But also, above all things, I don't want us to idolize ivermectin. I don't want us to think that if ivermectin doesn't work, or if I started too late, then there's no hope for me. Because ultimately, this is a gift from God. And if doctors, physicians like me, if medications do not help, We must not lose hope and thinking that because there's no solution within the realm of men, there's no solution in the realm of God. We still have to continue trusting God for healing, because healing ultimately is an art of God, is the science of God. Healing, I can give you the best medications, we can hit it at the best of times, but ultimately we need to always remember this is not our little idol that we are busy idolizing now. It's a gift from God, yes, but at the same time, our trust must always be life is from God. And therefore, whatever you do, even if you think that you have hit the end of the road, do not give up, do not panic. Lay your anxieties on him, and he will really give you the peace that you need to weather the storms. So with those words, viewer, and thank you so much for making this opportunity for us to share with the people. I love your perfectionism. You know my videos most, they always come kokai. But I thank you so much with your team for putting up this brilliant and professional presentation for us. And I pray and hope that our people are going to go back, even in the quietness of their time, when they can, and go through these videos. They can always WhatsApp me. Oh, sorry, not WhatsApp. They can always inbox me. If they need to WhatsApp me, I'm going to leave them the WhatsApp for my PA. They can always WhatsApp Rose. Rose is my PA. She is more than willing to communicate and you know and initiate the conversation, because I personally cannot keep up with all the conversations. Her number is, you can put it here, Rose Peterson. She is my PA. So when I say speak to Rose, I'm not chasing you away. I'm just making my life easier. It's 061 412 0942. Rose at 061 412 0942. You can get her on Facebook. You can also WhatsApp her. We can send a message. She will take it from there and help you out. 061 412 0942. Thank you.
Thank you. Thank you very much. On that, Kepingzo, we have come to the end. Oh, there, over there. It's the number is there.
Thank you.
Thank you. Thank you so much. And we will get together, and we want to thank you. We ran over by 13 minutes, but I also want to thank Duga. Beautiful visuals and our framing, whatever our frames and the poster, and you, Tembi, for making sure we start on time. I'm sorry, guys, I didn't realize that we're already live. I think we lost about 59 seconds, but thank you very much, everybody. We really appreciate.
Thank you.
Okay,
Thank
then.
you.
Okay, then. Bye.
Bye.